Hope this instruction course will help improve your techniques of CCC and make each one of you a more confident and better cataract surgeon. Let's start with the first talk, the Perfect CapsulorrheXis Principles and Techniques by Dr. Kirtana Sakariya. Dr. Kirtana, after her post-graduation and phaco training, has worked as phaco surgeon at Mother Care Hospital, Palakkad. Currently, she is in the process of building her own practice at Ernakulam. Over to Dr. Kirtana.
Thank you, ma'am. So, good morning, everyone. We'll start the session with a very basic topic, the principles and techniques of a perfect capsulorrhexis. So, why do we actually need a continuous curvilinear capsulorrhexis? So, CCC rim is mechanically more stronger as compared to a capsulotomy rim, and it has less risk of tearing during chopping maneuvers. And it has no flaps or tags which can get stuck between the instruments. Also, it gives a better IOL positioning. Now, what are the principles while we make a CCC? So, basically we are making a circular opening on the anterior lens capsule, and in doing that we are making use of certain forces. So, let us understand those forces briefly. So, first is a shearing force. So, in simple terms, it is a force that we use to tear a paper, as I have shown in this illustration. So, on one side there is a flap and we fold it over and pull it in the direction in which we want the material to tear. So, when it comes to capsulorrhexis, we are using this shearing force along with a force that is directed towards the center of the rhexis to get a circular trajectory. So, these two forces have to be balanced to get a circular trajectory. So, that is the main principle. Now, we also use a ripping force sometimes. So, here we are holding a paper on both sides and pulling it apart. So, the force is applied perpendicular to the direction of the tear rather than in the direction of the tear. So, this force is mainly used while we are rescuing a runaway rhexis. So, these are the main forces that we use. Now, regarding the ideal sizing of a capsulorrhexis, so the CCC should be large enough for easy nucleus removal and IOL implantation. At the same time, it should be small enough to maintain the capsular integrity. So, if you are doing phacoemulsification with a foldable IOL implantation, then the ideal size would be around 5 to 5.5 millimeters, so as to get a small optic overlap by the rhexis rim, since most of the foldable IOLs have an optic diameter of around 6 millimeters. So, this gives a better IOL positioning and reduces the chances of posterior capsular opacification. Now, if you are doing SICS and you have a large and dense nucleus, then you require a larger rhexis. And also, if you are operating on an intumescent cataract, then you might require an initial smaller rhexis followed by enlargement later. Now, if you are a beginner, you can use a rhexis marker if you want to guide your rhexis size. So, this is a corneal rhexis marker. It has two rings. The inner ring has a diameter of 5 millimeters and the outer ring has a diameter of 6 millimeters. So, you can make a corneal impression with this marker and you can do the rhexis between these two rings. So, you get a diameter of around 5.5 millimeters. Now, regarding the instruments that we use for CCC, you can use a cystotome or forceps like Utrata or microrhexis forceps. So, the most easily available, the most commonly used and the most basic instrument is a cystotome. So, in this talk, we will be discussing mainly about the technique of capsulorrhexis using a cystotome. So, how do we make a cystotome? So, we use a 26 gauge needle for this. You can attach it to a 2cc syringe or a tuberculin syringe. And it is always advisable to bend the needle under microscope in good illumination and high magnification, keeping it focused on the needle correctly. So, keeping the needle in bevel up orientation, hold the needle at the bevel with a good needle holder and bend 1/3 of the length of the bevel downwards to an angle of around 70 degrees. Now, keeping the needle in the same orientation, the second bend is made towards the hub of the needle upwards to around 60 degrees. So, at the tip we are making around 70 degrees of bending and towards the hub we are making 60 degrees of bending. So, these are approximate angles and the second bend the angle of the second bend can be slightly modified according to the depth of your AC. If you have a deeper AC, you can bend it lesser, and if you have a shallower AC, you can bend it little bit more. Now, before starting the surgery, make sure the surgeon is positioned comfortably with a straight neck and back. He should not be crouching or hyperextending his neck to get a proper view through the microscope. And the patient head positioning is equally important. The chin and forehead should be at the same level, parallel to the floor. If the chin is tilted downwards, you can tilt it slightly up to maintain the position. And if the neck is hyperextended, then you can keep a folded towel or a ring under the head to maintain the correct position. Also, the head should not be tilted to either side. Now, hand positioning of the surgeon, the elbows should be making an angle of approximately 90 degrees. And the most important point is that the hand should be supported at the wrist and you should be holding the cystotom like a pen. Now, regarding the surgical steps before we reach CapsulorrheXis, so the side port incision should not be very wide. It should be ideally less than 1.5 millimeters so that it causes less leakage of visco when you are doing the CapsulorrheXis. Now, the next important step is staining of the lens capsule. So, this is done for proper visualization during CapsulorrheXis. So, it is always advisable to stain the capsule if you are a beginner or if you have a poor red glow, as in dense or mature cataracts. So, the dye that we use is trypan blue. So, what is the technique of staining? You first inject an air bubble into the AC and then inject the dye under the air bubble into the AC. And this is done to decrease the exposure of the corneal endothelium to the dye, and after waiting a few seconds you can wash out the excess dye with BSS. So after staining you should be having a uniformly stained capsule. The staining should not be patchy. Now you can also do your rhexis under retroillumination by turning on the red reflex button on your microscope if the cataract is not very dense or mature. So you'll be seeing the rhexis rim as shown in this video when you are not staining the capsule and doing it under retroillumination. But for beginners, it is always advisable to always stain the capsule rather than using retroillumination alone. Now the next step is to fill the anterior chamber with OVD. So why do we actually need this step? So when the AC is adequately filled with visco, the radial forces applied by the zonules on the anterior lens capsule is much less. So the chances of rhexis running to the periphery is decreased and you get good control while doing the rhexis. So the OVD most commonly used is 2% HPMC. You can also use cohesive OVD if the AC is very shallow. So cohesive OVDs maintain space much more than HPMC. So if you have a shallow AC or if you need to enhance the pupillary dilatation a little bit, you can use cohesive visco. Now while injecting visco, make sure that you inject it from inside out so that the AC is adequately filled. Then you can also put a little bit of visco on the cornea so that the cornea doesn't dry up very easily in between the rhexis. Now you are ready to start your CapsulorrheXis. So first introduce your second instrument or the dialer with your non-dominant hand through one of the side ports. And this second instrument helps to keep the eye stabilized in the central position. Now you can introduce the cystotome with your dominant hand through the other side port. So when you are doing this, make sure you tilt the cystotome sideways before entering so that you do not injure the side port. Also, this has to be taken care whenever you are entering or exiting the eye with the cystotome. And also make sure that you do not press the posterior lip of the side port while doing the rhexis because that can cause more leakage of visco. Now, after entering, make the initial puncture on the anterior lens capsule at the center and then extend this incision radially for about 2 to 2.5 millimeters so that you get a final diameter of around 5 to 5.5 millimeters. While doing this, avoid digging in and disturbing the cortex because that can make the flap identification difficult. Now, you raise a capsular flap, fold it over itself and direct this flap in a curvilinear fashion to get a circular rhexis. So how do we actually turn the flap in a curvilinear fashion? So you have to engage the cystotome at the flap close to the tearing edge and then use rotating movement at the fingertips to turn the flap. So as you can see here, this is a movement that you should use while turning the flap. Now as you continue, remember to reposition the cystotome intermittently on the flap close to the tearing edge so that you get better control of direction while continuing the rhexis. Now, as you continue, whenever you notice any AC shallowing, which is evident by either corneal folds or if you notice that the flap is freely floating in the AC, then it means the AC is getting shallow. So you need to refill the chamber with visco and always keep the flap flat. Now, as you reach the side port area, the rhexis maneuvering becomes difficult. So if you have noticed, until we reach the side port area, we are pulling at the flap to continue the rhexis. But when we reach the side port, you need to change the direction of the needle and to push the flap to continue the rhexis further. Also, you need to engage the flap at a point little away from the tearing edge rather than close to the tearing edge when you come to the sub-side port area. So these 2 points have to be kept in mind when you reach the side port area. Now, regarding the completion of rhexis, so always end the rhexis by turning the flap outside in. So this is how you finish the rhexis, by turning it outside in. So that's it. So if you have an inside out ending, what happens? So this area has an inherent weakness and it can easily tear with minimal force. But if you end outside in, this area is strong enough to withstand the stretching forces. This is the final CapsulorrheXis margin that you have. Now you have other modalities, newer modalities nowadays for achieving perfect capsulotomies like the femtosecond laser or the Septo device. And for beginners, it is always advisable to practice on other objects before actually starting on a patient. So you can practice in a God's eye in the wet lab, or you can even use vegetables at home to practice, or you can even use the used IOL boxes with the plastic film over it to actually practice your rhexis. So know the principles thoroughly, take care of the small points while you are practicing rhexis, like how to bend the cystotome, what is the angle, how to hold the cystotome, how to enter with the cystotome. So all these points have to be kept in mind when you are practicing your rhexis. And manual CCC is definitely an art that can be perfected only with practice. So practice, practice and practice. Thank you.
Thank you, Kirtana. It was a wonderful talk, and I hope all beginners, it was useful for beginners. Now, next talk is on the CCC secrets to manage complex cataract by Dr. Jilu George. She is a consultant in cataract department at Giridhara Institute after completing her fellowship in cataract surgery.
Thank you. So, Dr. Kirtana has explained the pearls for a perfect CapsulorrheXis in a normal routine cataract. Now I will be dealing with the CCC secrets to manage complex cataracts, specifically in terms of complexity regarding the CCC. So what makes your CCC complex? When you are in the beginning stage of your surgery, everything will make the CCC complex, right? You have an uncooperative patient with a very sunken eye or problems with bending the instrument, holding the instrument, anything can make your CCC complex. But once you are experienced enough, these are all not a bother, and the availability of a good microscope with red glow and the availability of proper instruments can help in doing your CCC. But what matters most, even for an experienced surgeon, is the patient factors. So patient factors, basically your CCC becomes complex either because of a problem with the visibility of the capsule or a problem with the stability of the capsule. So what are the causes for problem with the visibility? It can be due to a corneal haze where you have problem with visualizing both the capsule as well as your instrument, or it may be because of the density of cataract, vitreous haze, retinal detachment, where you have a problem with seeing the capsule but your instrument can be visualized. Or it could be due to a poorly dilating pupil. So coming to a patient with, in all these cases, irrespective of the cause, the basic principle is that you have to stain the capsule. If you are an experienced surgeon, in a routine case you can do without staining, but in these cases everybody has to stain the capsule and it has to be complete. So when you are doing a patient with corneal haze, here we can see that almost half of your area is hazy, but the rest half is normal. So in such a case, try to start your CCC from a normal area so that you can exactly guide the size of your rhexis. And once you enter the area of the haze, if possible, do it in a single stretch. If you take out your instrument in between that, then you might find it difficult to continue that, because you might find it difficult to see where your rhexis is. But once you have come out of the area of the haze, then it becomes like a normal case, so you can take out your instrument if needed. And regarding the density of the cataract, in a mature or a hypermature cataract, you already expect that your visibility is limited. But even if it's not a mature cataract, when you have a very thick cortical cataract or a very diffuse PSC, again you will find difficulty in visibility. So if you are in doubt, at the beginning of the surgery, just put the red glow and see whether the red glow is proper. In any case where this is not the case, you have to stain the capsule, and the general principles are the same as already explained. Now coming to a poorly dilating pupil. So when you have a poorly dilating pupil, you need to dilate the pupil to visualize the rhexis. When to use a dilating method and which method to use depends on a case-to-case basis, and also depends on the experience of the surgeon with the various methods. Now, in all these cases, again you have to stain the capsule. So this is a patient with uveitis with membranes over the pupil and posterior synechiae, resulting in a very poor dilatation. In these cases, the first step is that you have to remove the membranes and release the synechiae, which itself will improve the dilatation to some extent, which may or may not be enough for your surgery. In this case, the dilatation has improved, but it is not enough for your surgery. So you are dilating the pupil with Kuglen hooks. So basically you are using 2 hooks to stretch the pupil in opposite directions, and you can do it in multiple areas to get a irregular but dilated pupil, and you can do the rhexis properly. Now the problem with stretching the pupil is that you do it at the beginning of the surgery. There is no guarantee that the pupil will stay like that till the end of the surgery. So in cases where you expect that, it may not be the case, especially in cases where you expect, like in IFIS, you should never go for stretching of a pupil. You should choose a device which will stay in the eye and keep the pupil dilated until you require. So you have various methods for that. Basically you have the hooks and the rings. So just a basic overview. In all these cases, one point you have to remember is that when you are staining the capsule, you have to go under the pupil and stain it, because otherwise once you dilate the pupil, the area where you are going to do the rhexis will not have stain. Now, when you are using hooks, you can use 4 or 5 hooks, and you have to remember that the shape of the pupil will depend upon the number of the hooks that you use. So in this case, because you are using 4 hooks, you are going to get a square shaped pupil, and you are doing a circular CCC in a square shaped pupil. So the size, shape and the position of your CCC you should have in your mind. Like in a normal case, you cannot depend on the pupil size or shape to guide your rhexis. So if possible, you can use a rhexis marker. Otherwise, you should have it in your mind how to do the rhexis. Whereas when you do a BHEX ring, you get a slightly more regular pupil, but still it's not a circular pupil. Now, whichever method you use, at the end of the surgery, you are going to get a slightly dilated, irregular pupil which is not reacting to light as in a preoperative pupil. So, do you need to dilate the pupil in all the cases? For example, in this case, the dilatation is not very poor, but it's not enough. So, when you are a beginning surgeon, in this case, you have to dilate the pupil. But once you are experienced enough, you have another option where you go slightly under the pupil. Basically, you are not seeing the edge of the rhexis, but you know where it is. Okay. So in this condition, you have to refill the AC multiple times with viscoelastic, because you need to get whatever dilatation you can get. And like Dr. Ketana explained, when you reach the side port area, you have to change the direction of your instrument. Now here you are not seeing the rhexis, but you have to change it. That is why I said this should not be done by a beginning surgeon. It should only be done by someone who is really familiar with a normal CCC. The advantage in this case is that at the end of the surgery, you are going to get a regular round pupil which reacts normally. So that was about the problems with the visibility of the capsule. Now coming to the problems with the stability of the capsule, the stability can be affected because of either because the zonules are weak, or the zonules might be intact, but it's because of the type of the cataract. So far we have been discussing about doing CCC with a cystitome. Now, why are you able to do it with a cystitome even when it is not holding the capsule? Because you have a support that is given by the underlying nucleus. But when you have a problem with the stability, this support may not be there. So there you will require instruments which will hold the capsule and help you doing the CCC. So the most commonly used instrument will be the Uttrata forceps, which is used through the main port. Because you are using it through the main port, if you are not holding your instrument properly, the OVD will come out and your chamber will be shallow. So in such conditions, what you can use is a microcapsulorrheXis forceps, which can be used through the side port. Now because it is used through the side port, the chamber will be much more stable. But what you have to keep in mind is that when you are using this instrument through the side port, at the area of the side port, if you release the capsule, you will find it difficult to regrasp it. So either do it in a single stretch near the side port area, or when you reach the side port area, you will need to go to the main port to complete the capsule. Now coming to zonular weakness, in many cases preoperatively you might have diagnosed zonular weakness, either because of your slit lamp finding, or you might have looked very carefully because there is a history of trauma, or there is pseudo exfoliation or something like that. But in many cases you will miss the weakness preoperatively. Now when you miss a case like that, very often the first clue regarding zonular weakness is this. You can see that when you are trying to start the rhexis, the capsule is getting wrinkled. So you find it difficult to continue it with the cystitome, you are switching to a microcapsulorrhexis forceps. So again, as I said, when you reach the side port area, you might have to go to the main port to complete the rhexis. The rhexis has been completed, but it's really small. So because there is zonular weakness, you are going to use capsule hooks. And with the help of the capsule hook, the surgery was completed, CTR put, IOL put, and the hooks removed. Now, because the rhexis is very small, at the end of the surgery, you are enlarging the rhexis so that it becomes ideal size. Now, do you need to use these instruments in all cases of zonular weakness, or can you complete it with the cystitome? So, this is a patient. This is a case of pseudoexfoliation with poor dilatation and zonulodialysis. So because it's a poorly dilating case, you have to dilate the pupil first, and since you are planning to use capsule hook, you are going for a stretching the pupil. You are not using iris hooks. Now after dilating the pupil, basically what you can see is that you are starting the CCC with a cystitome. Once you get a little bit of the rhexis, you put a capsule hook at that point. So that part of the capsule becomes stable. And as you proceed with your rhexis, you keep on inserting capsule hooks so that you are completing the CCC with the cystitome, but with the help of capsule hooks. So this was about a patient with zonular weakness. Now in patients without zonular weakness also, because of the type of the cataract, you can have difficulty in CCC. Mostly this is seen in intumescent cataract where your cortical fibers are so swollen and you are not getting the support, or it might be a Morgagnian cataract where you have a very small nucleus which is rotating in the back, which is again not giving support, or you have like a fibrotic or a fragile capsule. Now these type of cataracts, they have their own set of considerations and complications which will be dealt in detail by Dr. Tindu. So over to Dr. Tindu. Thank you.
Thank you, Dr. Zilu, for giving us a wonderful insight about handling rhexis in complex cataracts. Now I invite Dr. Tindu to take us through the key points in managing capsulorrhexis in the white and the black cataracts. Dr. Tindu has completed her long-term fellowship in anterior segment and is now working as a consultant in cataract and glaucoma services at Giridhar Eye Institute. Over to Dr. Zilu. Dr. Tindu. Sorry.
Okay, thank you. Good morning, everyone. My topic is on handling hypermature cataract, the blacks and the whites. So we'll be dealing with the challenges and how to tackle it. So the first challenge is there is no red glow in a mature or hypermature cataract. So the only way to visualize the anterior capsule is by staining the capsule. So uniform staining with trypan blue is very important when you deal with a mature hypermature cataract. When the capsule is well stained, you can see a well demarcated rhexis margin, both in white as well as in black cataracts. But a poorly stained capsule or patchy staining means you are inviting complications. So this is also a stained capsule, but there is no staining at the center part of the capsule and you can't visualize where your rhexis is going. You won't see the rhexis margin and you may not realize even if the capsule extends. So don't do such bad staining. Staining should be proper when you deal with a mature cataract. The only disadvantage of capsule staining is that it makes the capsule more brittle. The second challenge is capsular plaques or fibrosis. These are the areas of the capsule which are thickened and resist tearing. So initiate your rhexis away from the area of capsular fibrosis. Since the capsule is very thick, it's better to use forceps. Here, a microrhexis forceps is used to complete the rhexis. Since the fibrosis is confined to central part of the capsule, you can easily do a rhexis beyond the area of fibrosis. But whenever there is an extensive fibrosis, like in this case, it's very difficult to get a continuous curvilinear rhexis because you need to cut the rhexis at multiple places. Here near the side port area, we cut it with 1 hour. Now again with microrhexis scissors, we are cutting. The advantage of fibrosis is that it may not extend at the area of fibrosis, but there is a chance of zonular dehiscence because of lot of manipulation. So be careful when you deal with a extensive fibrosis. The biggest challenge in a white cataract is raised intralenticular pressure. It's a challenge even for experienced surgeon. As soon as you touch the capsule, what you just saw was a Argentinian flag sign. Okay. So, So whether all white cataracts are intumescent? No. Okay. We can assess it preoperatively by checking the anterior chamber depth, anterior lens convexity, looking for fluid pockets, and even with the anterior segment OCT. So usually intumescent cataracts are seen in younger patients with swollen anterior cortical fibers. In such cases, usually the anterior chamber will be shallow with a convex anterior lens capsule. And when we initiate the RHEXIS, in young patient, if there is a fluid leak, actually the intumescence comes down or the intralenticular pressure comes down, and you can actually go ahead with the RHEXIS safely without much risk of extension. But in cases where there is no fluid leak, the intumescence remains the same and there is high risk of RHEXIS extension. Also, when you deal with a hypermature cataract, when patient presents to you, if the patient have a red eye or a painful red eye, always check the intraocular pressure. Okay, with raised intraocular pressure and shallow anterior chamber, if it's a phacomorphic glaucoma, or in case of phacolytic glaucoma where you have lens proteins in the anterior chamber, you should control the intraocular pressure and inflammation before proceeding with the cataract surgery. So we'll just see a normal RHEXIS in a hypermature cataract. This is a hypermature cataract after normal staining and putting visco. The RHEXIS was initiated with cystotome. There was little bit of fluid leak, but with cystotome itself, there is no extension, so you can easily do a RHEXIS here without much intumescence. Okay, this is also a hypermature cataract, but as you are doing the RHEXIS, we can see there are some folds in the anterior capsule. Like how Dr. Jilu have mentioned, this was because there is no support of the lens while doing the RHEXIS, mainly because it's an absorbed cortex, like in a Morgagnian cataract. Okay, so in such cases, because of the lack of stability, it's actually better to use a forceps to do the RHEXIS. So here, while doing the RHEXIS, near the side port area, there is a tendency to extend. So the main wound was used, and intrata forceps was used to grasp the capsule and pull it towards the center, and the RHEXIS was completed. Whenever you are putting any instrument through the main wound, there is more chance of OVD leak and AC shallowing. So always make sure your AC is filled with enough OVD. When you have any suspicion of intumescence, then always better to do a two-stage procedure or double RHEXIS. So we'll see how to do a ideal double RHEXIS. After staining the capsule here, since the AC was shallow, cohesive viscoelastic was used. RHEXIS was initiated with a cystotome and with a micro RHEXIS forceps. The mini RHEXIS or a small RHEXIS is started. Okay. It's better to use the side port because the OVD leak will be less when you use the side port. Once the mini RHEXIS is done, you can decompress the capsular bag by aspirating the cortex. And now, after decompressing the capsular bag, you have to enlarge the RHEXIS. For enlarging the RHEXIS, this is a micro RHEXIS scissors. Okay, that also can be inserted through the side port, and you can see the angulation of the cut. It should be tangential to your RHEXIS margin, because if you put a perpendicular cut, that cut itself can extend because of the centrifugal forces of the anterior sonus. So always make a tangential cut on the RHEXIS margin. And again, we are using a RHEXIS forceps to enlarge the RHEXIS. Okay, so this can be done through the side port or main port with micro RHEXIS forceps or with utrata forceps, depending upon your convenience or your comfort. This is also a intumescent cataract. Here you can see initially while doing, we are using shearing force, but because of the tendency to extend, the RHEXIS is pulled to inside, or ripping force is used. Because there is lack of control, the main wound is used. So depending upon the case or depending upon the intumescence or the elasticity of the capsule, you may have to change. Okay, so it's not an ideal case for a beginner because you can't predict how your capsule will behave. Now, like how Kirtana have mentioned, unstable cuts, RHEXIS cuts can extend at any point of time. So this was also an inside out cut. You can see how nothing was done and the rhexis just extends like that. Especially in intumescent cataract, this can happen. Okay. Even if there is no unstable cut, with our manipulation also we can extend the rhexis. So here, see, forcefully decompressing the capsule. I already told hypermature cataracts have a fragile capsule and it can just tear if you manipulate the rhexis, the capsule so much with the instruments. Better to avoid sudden shallowing while doing the rhexis. So in this case, while doing the second rhexis or while enlarging the capsule, you can see there is fluid leak, OVD leak through the side port. Okay, and there is faults in the cornea. This shows there is AC shallowing. And see what happened when the instrument was taken out? The rhexis was already extended. So avoid sudden shallowing of the AC when you're doing the rhexis. This is for the beginners. When you're doing for the first time with a rhexis forceps or a rhexis scissors, micro rhexis scissors, you should know how big is your instrument or how the instrument have to be used. So this is a case when the micro rhexis scissors was, when I was trying to put the instrument inside, there was lot of resistance and suddenly there was a giveaway and it went and hit onto the capsule, causing extension and even a PC rent. So this could have been avoided if the side port was slightly made bigger rather than struggling through that side port. With all these challenges, you know, making an ideal size rhexis is always a challenge in white cataracts or intumescent cataract. Either it can become too big and get extended or it can become small. So when it is small, you can extend or make it bigger at any point of time. This was a young patient with just cortical cataract which was aspirated. So after removing the cataract, the rhexis was made bigger after putting the cohesive viscoelastic with micro rhexis forceps. You can do it at any stage. So this is a case where even after putting the IOL, the rhexis was made bigger. Because especially in the second case, it's a case of pseudo-exfoliation also. In such cases, the risk of phimosis is very high if you end up in a very small rhexis. So to summarize, what are the things to remember? So always uniformly stain your capsule or paint the capsule with the dye. Don't overpressurize the anterior chamber, but maintain your anterior chamber, avoid OVD leak and refill if required. Careful in case of tags, it can extend at any point of time. Keep rhexis forceps and scissors ready when you are dealing with a complex case. Titrate your wound and know your instruments when you are doing. Choose the technique and instrument wisely. Thank you.
Thank you, Dr. Tindu, for that wonderful talk. Next up is Dr. Rosana Thomas. She will be dealing with how to prevent extension and once it extends, how to deal with it. Dr. Rosana Thomas is a consultant in the Department of Cataract and Glaucoma Services and Head of Community Ophthalmology at Girdhara Institute. After a long-term anterior segment fellowship, she has been performing cataract surgeries for more than 12 years. Over to you, Dr. Rosana.
Thank you, Dr. Jilu. In every case of cataract surgery, we would like to have a perfect CapsulorrheXis, but this does not always happen. The superiority of a CapsulorrheXis, as Dr. Kirtana has said, is in the fact that it does not have any free edges. But when the rhexis extend, this advantage is lost. A primary capsular tear is one that occurs while we are performing the CapsulorrheXis, whereas a secondary tear occurs due to extension from a ragged edge or a V-shaped notch. Today we will be dealing with primary capsular tears. So, when a tear extends, what can be the problems? The most important among them being a posterior capsular rent and its related problems. In many cases, we see extension of the CapsulorrheXis, but thankfully, most of these extensions do not extend to the posterior capsule, which is very infrequent. This is due to the fact that the presence of insertion of zonules prevent the rhexis extension to the posterior capsule. So which are the eyes that can have a CCC extension? In fact, any eye can have an extension, but more so in those eyes, as Dr. Jilu has explained, with complications. And any patient or surgeon who is uncomfortable on table can end up in a rhexis extension. Prevention is always better than treatment. And I would like to again emphasize all the key principles that the previous speakers have talked about, and we cannot talk enough about these. They should be done in every case. In spite of all the precautions taken, sometimes the rhexis again decides to run off radially. At this stage, our aim is to prevent its posterior extension into the posterior capsule. The moment you realize that the rhexis is running off radially, stop. Fill the anterior chamber with a viscoelastic, which will flatten the anterior capsule. In many cases, this maneuver itself will prevent the extension. And if the rhexis has gone beyond the pupillary margin, retract the pupillary margin for a better visualization. Reassess the situation and then plan according to the situation. Never hesitate to call for help, especially if you are a beginner, in case the need arises. Iris hooks can be used at any stage during the surgery. Even when the rhexis extends, you can apply iris hooks. A high molecular weight with cohesive viscoelastic is very useful in these stages. And in case of a very shallow AC or a high positive pressure, you can use an infusion of OVD through a second side put. The Little's maneuver is a technique which can help rescue a rhexis that is running away in many cases. According to Dr. Brian Little, the direction of an errant CCC can be reversed by redirecting the forces in the direction opposite to that of the tear. That is, if the rhexis is going out, pull it in so that it comes back. This is a case of a hypermature intumescent cataract where we are trying to make a small microrhexis first. And we would like to make the rhexis, we would like it to go circumferentially. But look here, the rhexis is trying to run radially. At this stage, stop. Go in and decompress the capsule. Put a high density, high molecular weight viscoelastic, flatten the anterior capsule, and now change the direction of pull. Pull the flap from the root inside so that the rhexis slowly comes back to its original location. The Little's maneuver can be done even if the rhexis has gone beyond the pupillary margin but has not gone up to the equator. The rhexis will still come back to its original path. Now, even after all attempts to retrieve the rhexis, sometimes it extends to the periphery. At this stage, do not attempt to keep on pulling the rhexis. This can lead to more complications. Rescue techniques at this stage depends on the site of extension, that is, accessibility to the torn flap and also to the extent of tear. You can complete the capsulotomy from the opposite sides, or you can make relieving cuts in the flap edge and continue in the same direction. Many surgeons advocate creating extra radial flaps. These additional flaps help in redistributing the forces so that the tear does not extend to the posterior capsule. A can opener should be reserved as the very last resort only, and we do not usually advocate it. Be familiar with the special instruments. As the previous speakers have said, these are the microrhexis forceps, the microrhexis scissors, Utrata forceps, and so on, and also cohesive viscoelastics. Keep them ready in all cases. So this is again a case of a hypermature intumescent cataract. Here we are trying to make a primary small microrhexis. You can see the liquefied cortex that is leaking out. In our attempt to decompress the liquefied cortex, the capsule extends peripherally. But thankfully, it hasn't extended too much into the periphery, so we can attempt to include within our microrhexis. So this could be done and the microrhexis could be completed. This is another case of a hypermature intumescent cataract where the primary rhexis has been done and now we plan to do a secondary rhexis. For that we will use the microrhexis scissors. And as Dr. Tintu has said, we have made a tangential cut, but it is tending to run radially. Here a rhexis can be attempted in the opposite direction, that is the clockwise direction instead of the usual anti-clockwise direction. This is the reverse CCC. This is again a case of an intumescent cataract in a young patient. This is not hypermature, but still it has resulted in a Argentinian flag-like situation where the capsule has split into two. Here we will be using the microrhexis scissors to make a relieving cut in one half of the CapsulorrheXis. The cut is made and the microrhexis forceps is used to grab the tear and pull it circumferentially and thus complete one half of the rhexis. Now the other half might be inaccessible through the side port. So we can try to use either the main port or in case if it is possible, you can move temporarily or to any other convenient site, make a new side port which is more accessible to the rest of the capsule. Again, make a cut with the microrhexis scissors and use either the forceps or the cystotome to complete the other half of the rhexis. This is again another case of a hypermature intumescent cataract where while doing the secondary rhexis, the AC becomes again very shallow. Here look at the folds on the cornea. They show that the AC is shallowing. So when the instrument was taken out, suddenly the rhexis split. Again, a microrhexis cut was made and the forceps is used to complete the rhexis. This is another case of a hypermature intumescent cataract where the rhexis has split. Here again, you can go in, make a relieving cut with the microrhexis scissors and use a Utrata forceps or any other forceps to complete the rhexis. This is the classic Argentinian flag sign where the capsule has split into two. Again, you can use the microrhexis scissors to make a relieving cut and tear one half at a time with the microrhexis forceps. So, in a case of cataract surgery, now you have an extended rhexis, but you need to go on and finish the case. How will you decide whether to continue with phacoemulsification or do you need to convert to SICS? This decision depends on a lot of factors. Some of them being the skill level of the surgeon and the experience of the surgeon, the hardness of nucleus. If it's harder, better to convert. And also the presence of other associated complications like a small pupil or an unhealthy cornea or an unstable, uncomfortable patient, always better to convert to SICS. In any case of doubt, it's better to convert. In any case, the priority should always be the patient's safety and good vision at the end of surgery. So a very important clinical sign that helps us to make the decision whether to convert to SICS or continue with phaco is the flap motility sign. This helps to predict the extent of the anterior capsular tear. The capsular tear can either be pre-equatorial or post-equatorial. The pre-equatorial flaps are everted and fluttering. And in this case, you can safely continue phaco and place the IOL in the bag. Whereas a post-equatorial flap has extended to the PC and the ends are everted and non-fluttering. And this requires conversion to an SICS. So here you can see a pre-equatorial flap which is everted and mobile, whereas a post-equatorial flap is inverted. This is a case of a hypermature intumescent cataract where you can see the split in the capsule, and pay close attention to the torn edges. You can see that the edges are flapping. They are mobile and everted, which shows that the PC is intact. So in this case, you can safely go ahead and do the phacoemulsification and put the IOL in the bag. In case of continuing with the case of cataract surgery with an extended rhexis, be very gentle and careful in each of the steps. The hydrodissection and rotation should be very gentle. If possible, you can even avoid hydrodissection and rotation of the nucleus. The phaco settings should be low and do a slow motion phaco. Chopping techniques should also always be very gentle. Emulsification can be attempted in the AC if possible. Even cortical aspiration should be very careful and keep the area of extension for the end. Always remember that early recognition of an rhexis migration should be noted, and whenever it is noted, stop immediately. Refill the chamber, flatten the anterior capsule. Use microrhexis scissors and forceps and OVDs whenever the need arises, and keep a watch for flap motility sign. In a case of an extended CCC, with the proper management, you can have a very good outcome in most cases without any major complication and good vision. Thank you.
Thank you, Dr. Rosina, for the wonderful talk. We are at the end of our session. We hope it was an informative session for all of you. Any questions?